Okay, this is the fun part for me, hopefully for you. We're going to talk about nephrotic syndrome, hematuria, and proteinuria. And at the end of this, you should be able to do the following. First, we'll talk about proteinuria. Proteinuria is what worries nephrologists. Hematuria is what worries mothers. And we'll talk about, of the two, proteinuria is probably the more significant in terms of renal disease. Obviously, the most severe form of proteinuria is nephrotic syndrome, and therefore we'll focus on that, and then we'll talk about the teenager that comes in with 2+ protein on a regular urinalysis. Most of this data, and I'll make some modifications, but the way we derived most of the data, what we talk about, is the International Study for Kidney Disease in Children, which was a consortium of institutions, about 7 or 8 in the United States, 2 or 3 in Europe, 1 or 2 in Japan, and 1 or 2 in Australia, decided in the late 1960s to biopsy every single nephrotic that came in the door. And they did this, and all the pathology was sent either to Chicago or to Paris to do very famous renal pathologists. And then they looked at clinical criteria, and they then treated everybody with 2 milligrams per kilogram of prednisone for 4 weeks, and then alternate day prednisone for another 4 weeks, and they kept track of what they found. By the end of this talk, as you can see, you're going to know 93% of nephrology because you're going to know these 3 diseases. And this is what they found. Most of it was obviously minimal change. Some of it was focal segmental, and some of it was MPGN. The characteristics of minimal change were, how many of them were less than 6 years of age? Well, almost 80%. What percent were female? 40%. Obviously, it's more common in males than females. Hypertension can be present with minimal change. It's not characteristic, but 13% of them. Likewise, hematuria can be there. It was almost always microscopic. Gross hematuria would be very unusual. A low C3 is not characteristic of minimal change, but if you do 700 C3s on patients with anything, you're going to find a few abnormals. The cholesterol of less than 250 is very rare, 5%. Most of these children have cholesterols in the 300, 400, and 500 range. An increased creatinine can happen up to almost 33%. It's probably intravascular volume contraction, not renal function. And 93% responded to prednisone with total clearing of their proteinuria. So those were the characteristics seen in minimal change disease. This is sort of a classic kid with minimal change. It's a boy. He's got this ascites, which we'll talk about. And this is what makes treating minimal change fun for pediatric nephrologists. This is a girl. I have a full frontal, and her got massive ascites. This is characteristic, but 15 days later, that's the same kid, after 15 days of prednisone. So that's the fun part. Focal segmental is a frustrating disease, and in the international study described this disease, the characteristics were very similar to minimal change. More than half the patients were less than 6 years of age. Only 30% of them were female, so it's more common in males. 33% had hypertension. Half of them had hematuria, and sometimes it was gross hematuria. A low C3 is not characteristic of this either. Cholesterols were usually also very high, very rarely less than 250. An increased creatinine 40% of the time, and the response to prednisone was only 7% with total clearing of their proteinuria. What usually happened subsequently was they relapsed and then didn't respond, but that's the story. Oops, wrong one. And what we're talking about, you knew you weren't going to get through a talk with a nephrologist without seeing something, is This is a normal glomerulus. This glomerulus looks pretty much the same except for that one area, and that's the segmental scar. Focal, meaning you may have 30 of these and only one of these. Segmental, meaning this is pretty normal, but that's not. And interestingly enough, this has a worse prognosis than if this whole thing were sclerotic. If you just tell the whole glomerulus sclerotic, that doesn't carry a bad prognosis, but if you see a segmental, it does. The interesting thing about focal segmental is that this study was done and we sort of lived by this for the first 20 years. And then in 1990, things changed. And the first group to describe it was from Texas Children's in Houston, where they looked at their biopsies and they biopsied children who didn't respond to prednisone, who fit those age criteria, or they were older, as we'll describe. And they didn't change the reason they biopsied people. And 23% of their biopsies showed focal segmental glomerulosclerosis prior to 1990. And after 1990, almost 47% of the biopsies they did showed focal segmental sclerosis. And their question was, what's happening? And indeed, this was the beginning of something that is now a national thing. It's particularly pronounced in African American males, not females, but males. A study from the Children's Hospital of Eastern Canada in Ottawa, and there are relatively few African Americans in Canada, covered from 85 to 02, and the incidence of FSGS went from 0.37 to 0.97 per 100,000. So it tripled in incidence. It's also true in young adults. It turns out that in the 1970s, when this study was done, if you had an adult with nephrotic syndrome, you could pretty much bet they had membranous glomerulonephritis. Now, young adults age 15 to 50, it's the most common diagnosis seen in almost 35% of all biopsies. 50% of the biopsies in the black population, African Americans, shows FSGS, and particularly susceptible are the males. The frustrating thing about focal segmental is they don't respond to steroids. They don't respond to anything very well. Cyclosporine or tacrolimus has been reported to decrease or eliminate proteinuria in up to a third. The disease may recur in 30% of transplants, and we can't figure out which ones until it happens, which is very aggravating. There are some genetic causes of focal segmental sclerosis, and if we do a gene screen and find that there's a genetic cause, those patients do not recur. So we actually like to find those. Non-specific therapies include ACE inhibitors and angiotensin receptor blockers. These agents make sense if there's a reduction in renal mass and the genesis of the lesion appears to be hyperfiltration. And this is a slide basically showing in terms of autoregulation. This is for those of you that work in the nursery. When you give indomethacin, you shut off prostacyclin, which helps dilate this thing up, so flow into the glomerulus. If you shut the prostaglandin off, is basically shut off, which is why their creatinine rises. This is what happens in the efferent arteriole. Under the control of angiotensin, this constricts and increases filtration pressure across the filter. And so if you block this with an ACE inhibitor, you dilate it up and you keep this flow the same, and this is dilated, there's less pressure across and therefore less proteinuria. So that's why we tend to use this drug in almost any patient with proteinuria, because there's pretty good evidence if you can eliminate the proteinuria or decrease it, you can help stem the decline or prevent the decline of renal function. The third group was an interesting group. It was membranoproliferative. Only 2.5% were less than 6 years of age. 64% were female. This surprised me. 27% were hypertensive, and this was at the first time of biopsy. when they presented. If you follow these patients for a year, it's virtually 100%. Hematuria was 48%, also surprising to me, because when you follow these patients for a year, they all have hematuria. Low C3 and 74%. Cholesterol may not be that high. It's curious because this is also true of lupus, which is the other disease that's seen more in women than men. And the increased creatinine was 50%. The response to prednisone was not only 0, but there were anecdotal reports of causing malignant hypertension or hypertensive crisis. So these patients we did not want to biopsy, we did not want to treat with prednisone. So patients with minimal change disease respond to prednisone, and as you saw, that's 76% of them. Patients with focal segmental don't, but there was no evidence that a course of prednisone harmed them in any way. However, patients with membranoproliferative could develop severe hypertension, and so we did not want to treat those with prednisone. So that our decision to biopsy is the more characteristics they have of membranoproliferative, the more likely we are to biopsy. If we think they've got minimal change or FSGS, we treat them with prednisone and see what happens. If they're thought to have membranoproliferative, i.e. older women, low C3s, we'll biopsy first and then tailor treatment. Minimal change nephrotic syndrome. Remember that child, African-American boy that I showed with ascites? In the 1930s, minimal change disease had a mortality of 80 to 85%. And the reason is they would sit there with that ascites for months until they went into spontaneous remission. But before they went into spontaneous remission, they'd usually get strep pneumoperitonitis. And so what changed the whole outlook for minimal change disease was penicillin. Once penicillin was available to treat strep pneumo, the mortality rate dropped to 10%, and then it subsequently fell further as we got better. Today, that is still the most common organism seen in spontaneous bacterial peritonitis in a nephrotic. It shows up on boards every year. E. coli is the second most, and the third most is aseptic peritonitis, where you basically do your tap and don't grow anything. The second major complication, is thrombosis. Go back. Okay, where are we? And pulmonary embolism. And even in the most recent series in the late 1990s, there's still a mortality of about 5%. Thrombosis can now be obviously treated. When I was a fellow, I saw one patient that had lost a leg because of an arterial thrombosis. But now that same patient would get treated with TPA. And I've treated 3 or 4 patients who've had emboli or thrombosis of an extremity. And now we can save the extremity. But obviously somebody with nephrotic syndrome who shows up with unilateral swelling or swelling that's much worse on one side than the other, you need to think thrombosis. Minimal change disease, 93% responded, 7% didn't. I've only had one patient not respond who turned out to have minimal change. And what did his father do? He was a pediatrician, of course. But supposedly 36% never relapse. I don't see many of those. Infrequent relapse is about 18%. And 18%, what they mean by infrequent relapse, they mean less than twice in every 6 months. And what we usually do is treat with prednisone until they clear their proteinuria. And then that usually takes about 2 weeks. And then we treat them with every other day prednisone for 2 weeks. And then we stop. So they're relatively small. Over the course of a year, they may get 3 courses of 2 weeks prednisone. But the frequent relapser, who's relapsing more often than 2 or 3 times in 6 months, is a significant problem. Because then if you're treating them all the time with prednisone, they have all the toxicities of prednisone, and they're still relapsing. So in that case, we use alternate therapies. I tend to use cyclophosphamide, which is the longest used therapy. You can give them 1 to 2 per kilo. You don't need to know the doses. For 12 weeks, and you have a 70% chance of putting them in remission for 3 or 4 years. My partners tend to use Cellcept or myclophenolate, which is also effective but has to be taken twice a day. Other things that can be used are chlorambucil, cyclosporine, and Prograf. If any of those of you are internal medicine peds, the critical thing is if they don't respond to prednisone in 8 weeks, stop it. It's not like the adults where you use very long courses, because if they don't respond, they're not going to. And obviously, after 8 weeks, you begin to have significant toxicity from your therapy. And the last thing you want to do is give them all the side effects of prednisone and have them nephrotic at the same time. So those are the ones we use alternate therapy. Congenital nephrotic syndrome. This is for the boards. This is rare. I've seen 3 cases, and I've done this for 40 years. It prevents early in life. That's why they, remember the international study, eliminated children less than a year of age, because most of those children have congenital nephrotic syndrome. They've got massive swelling. Oftentimes their history of where the placenta is as large, almost as large as the baby. There's an autosomal recessive, which is the Finnish type. Death is by year, and what is it? E. coli sepsis, remember that. The treatment, when we diagnose somebody, is daily albumin infusions. Sometimes we take out both kidneys with normal renal function and try and get them to grow and then transplant them in a year. They're good. When they get to 10 or 11 kilos, they're good transplant candidates. But they lose such massive amounts of protein, and they lose not just albumin, but very large molecular weight proteins. They're often very significantly compromised immunologically, and they're gonna die. And that's what you need to know about congenital nephrotic syndrome. There's often something on the boards, and under a year of age, you consider congenital nephrotic syndrome. There are a number of genes associated with that, and we can now test for them. If you test for them and find them, in most cases, it's an autosomal recessive inheritance. Orthostatic proteinuria is seen in teenagers, and that's what you're going to see in the office, essentially, in terms of the best thing for my business is when people do screening exams and screening urinalysis right after football practice, because they have protein, they have blood, they have all kinds of stuff in their urine. They get sent to me, and there's nothing wrong. But this was discovered in World War II because you used to get thrown. They threw you out of the Army. The Army didn't want to take care of a whole lot of people with chronic renal disease. And what happened is they found a group of people who spilled protein only when they were standing. And a guy named Roscoe Robinson, who is head of nephrology at Duke and then subsequently dean of the school at Vanderbilt, followed patients for 40 years. And what he showed you was the fact that if he laid them down, and he did this in World War II, for 5 hours and then got a urine sample, there was no protein, but he got them up and stood them and walking around, and within 2 hours they had protein in their urine. That's a totally benign disease called orthostatic. This is the way I used to test for it. I became very unpopular because this is 8 o'clock at night, and then I have them go to bed, and I get one at 10. There's still a little cloudiness, and the cloudiness is protein. It's with sulfosalicylic acid. 3 o'clock in the morning, I don't let them get out of bed to pee, which made me very unpopular. And that's clear, and this is relatively clear, and then they get up and walk around, and sure enough, there it is again. And that's a totally benign disease. A third of the time it goes away, a third of the time it's always there, and a third of the time it comes and goes. But in terms of, it makes things easy from the standpoint of, now what do? I give them a urine container. I ask them to pee before they go to bed at night. I tell them to have a little something to drink. And as soon as they get up in the morning, I want them to bring that first morning urine into me. because if that's negative, I'm fine. Proteinuria, in order to be important, has to be persistent, meaning it's there every time, and non-postural. And so if you start finding 10 urines and 7 of them have protein but 3 of them don't worry. And basically, if they're greater than 7 years of age, we look at the 24-hour urine protein, and now we're doing a urine protein to creatinine ratio. And if they're sort of halfway to nephrotic syndrome, we'll consider biopsying them. In point of fact, what I usually do is follow them 2 months later and see if it's getting better or getting worse. If it's getting better on its own, I don't want to biopsy them. If it's getting worse. If they're less than 7 years of age, some people would actually treat them with prednisone. I usually just follow them and see what happens. Again, patients greater than 7 years of age, as you know, are much less likely to have minimal change. That's why I chose that one. Now, hematuria. Hematuria scares mothers to death. It's much less worrying to me than proteinuria, and the evaluation with a patient with both hematuria and proteinuria would follow the guidelines already presented for the evaluation of proteinuria. But if it's just hematuria, what do you deal with? First, you eliminate the fact that they don't have hypertension, they don't have any of these things. And you consider strep. And the one test for acute glomerulonephritis and hematuria would be a C3. If you say, well, it's an ASO titer, you can just do random ASO titers and 20% of the population will be positive. If somebody comes in with acute glomerulonephritis and the C3 will be low for about 4 to 6 weeks in the acute phase, and then it will come back up to normal. So it's only good when they acutely come in. But for isolated hematuria, the primary considerations are hypercalciuria, IgA nephropathy, and sickle cell trait. That accounts for most of them. I did a study in the 1980s, 54 kids that had gross hematuria, only gross hematuria, for a month, or 3 episodes of gross hematuria in 6 months. And of 54 kids, 13 of them had hypercalciuria, 12 of them had IgA nephropathy, and 4 of them had sickle cell trait. Hypercalciuria, increased urinary calcium excretion. 80% of them will have a positive family history of stones. Patients may complain of dysuria and or frequency, and these are the patients I often see who've complained of dysuria and frequency, been taken to the emergency room, found to have hematuria, treated for urinary tract infection, and the culture either was not done or was negative. And that happens 3 or 4 times, and then I end up seeing them. And I usually bet on hypercalciuria at that point, because high urinary calcium will cause frequency and sometimes dysuria. You can do a calcium to creatinine on a random urine. It should be 0.2 or less. If it's higher than that, it's probably hypercalciuria. I had to show these just because they're so pretty. These are calcium oxalate crystals. I think I did another picture under refraction. And treatment is to increase fluid intake, reduce sodium intake, because proximally, the proximal tubules where both calcium and sodium tend to be reabsorbed. And if you have a high sodium intake, you decrease sodium reabsorption proximally, and that indeed decreases calcium reabsorption. A thiazide diuretic also decreases urinary calcium by causing sodium loss distally where you don't follow calcium. Don't decrease the dietary calcium intake. It actually causes an increase in stone formation. And the reason is 80 to 90% of all stones are calcium oxalate. And calcium oxalate is this stuff. Oxalate is in the diet. That's where we get it. Most people don't have a lot. It's in rhubarb is the biggie, spinach, tofu, chocolate. So it's usually not something that you see a lot of. But if you decrease the urinary calcium, oxalate precipitates with calcium. And most of oxalate that we eat will precipitate with calcium and we'll poop it out. If we decrease the dietary calcium, we increase the absorption of oxalate. If they've already got a fixed calcium leak, we've now increased both sides of the equation, calcium and oxalate going through the urinary tract, which increases the incidence of stones. IgA nephropathy, it's a diagnosis can be made only by biopsy. And indeed, in this study that I talked about that I did, I biopsied a number of children with gross hematuria. The question was, do they need a biopsy? And I came to the conclusion they didn't, because most children with IgA nephropathy are going to get better. Those that aren't, those 5 to 15% that have chronic disease, will have proteinuria as well as hematuria. So I follow them, and if they develop proteinuria, I'll consider biopsying them. You will almost always see red cell cast in somebody with IgA nephropathy. And that's indeed when I wanted to get this picture. I just waited for one of my patients with IgA nephropathy to come in, and because they almost always have red cell casts. 10 to 15% will develop chronic disease, but they'll have proteinuria, and they should be biopsied. The appearance of persistent proteinuria is a reason to do it. Sickle cell trait, hematuria is actually more common in trait than disease. They may develop severe hematuria. Fortunately, this doesn't happen in children. Very often happens in adults. It's almost always the left kidney. I'm not sure why. It's the hemodynamics. And it can be very difficult to treat. Other causes of hematuria include urinary tract infection, but it's not isolated hematuria. They've got white cells, they've got nitrates, they've got other things. Alports, hereditary nephritis, they can present with hematuria very early in life. Parents usually tell me, we're worried this is what they have, because Alports is an autosomal dominant in most times, and usually somebody else in the family has it, so they're exceedingly aware. Hydronephrosis can cause gross hematuria if you've got with minor trauma. And so patients who have developed gross hematuria with minor trauma, I usually get a renal ultrasound looking for hydronephrosis. Cancer. I had a patient literally 2 weeks ago, and this has become more of a problem rather than less of a problem. The pediatrician called me and said, this child has gross hematuria. He had done the C3, he'd done this. I said, would you check a urinary calcium to creatinine? And he did, and it was high, it was 0.4. I said, well, that's the reason. He talked to the family, and my secretary had this call and said, this patient, you've got a full clinic tomorrow, but this mother insists she has to see you tomorrow. Must see you tomorrow. It's urgent. It's necessary. And it was this patient who the pediatrician had talked to. And so I walked in the room and I said, so you saw Dr. Bennett and he told you with gross hematuria? And she said, yes. And I said, and then you saw Dr. Google. Because if you Google hematuria, what will come up? Cancer. And probably the most important thing I tell parents, this is not cancer. Then they don't really care what it is after that. But you need to be aware of that, because that's what they find. And you need to just say, Wilms tumor is the tumor they get in pediatrics. You will feel the tumor before you'll see the hematuria. It doesn't present as hematuria and then develop into the tumor. Wilms, as everybody knows, is an incredibly fast-growing tumor. And even in all those children that we get ultrasounds every 6 months, I've never picked it up, not once. Usually halfway between or sometime between, the parent feels an abdominal mass. So that's more important, is to teach mothers how to feel for an abdominal mass than the ultrasound. But that's the most important thing we tell about hematuria. Okay. So studies for isolated, I get a urinalysis, I get serum electrolytes, I get a CBC, I get a urinary calcium to creatinine ratio. Sickle cell screen is probably not necessary at this point because you have newborn screens, and now you know. Or you can check the newborn screen. But in the old days, we didn't always know that. If they've got gross hematuria, I get an ultrasound. Urine culture if they have symptoms of pyuria. This is just a list for your gratification. Non-glomerular causes, you've seen all these. Okay, 4-year-old boy presents with swelling, ascites, and a cholesterol of 648. 1 month ago, and he presents today for reevaluation after you've treated him with prednisone 2 per kilo and Lasix. Today he's less swelling, still has 4+. Proteinuria. What's the most likely diagnosis? Minimal change, focal segmental, membranoproliferative post-streptococcal, or IgA. Okay. This is a non-responder. If after a month of daily prednisone you haven't cleared your proteinuria, and remember, pediatric nephrologists are purists. It's there or it's not. We don't settle for a little less. So this is somebody who didn't respond. He's 4 years old. If you think about the 4-year-olds who don't respond to prednisone, it's usually focal segmental sclerosis. In contrast to that, a 4-year-old boy who presented with swelling, ascites, and the cholesterol of 648 presents for reevaluation. His proteinuria cleared, but every time his prednisone dose was switched to every other day, his proteinuria returned. Which is the most likely diagnosis? Minimal change, focal segmental, membranoproliferative, post-strep, or IgA? Before I started taking care of patients like this, I had hair. Right. This is minimal change, and he's probably going to be a frequent relapser. This is one that, in terms of if you can't switch to every other day prednisone without having him relapse, this is probably somebody that's going to relapse continuously, and you're going to have to use some other form of therapy in most cases. A 7-year-old girl has crampy abdominal pain, a rash on the backs of her legs and buttocks, as well as the extensor surfaces of her forearms. Laboratory analysis reveals proteinuria and microhematuria. She is most likely affected by which of the following? Systemic lupus, anaphylactoid purpura, that's HSP. I've got to change that. Post-streptococcal glomerulonephritis, polyarteritis nodosa, or dermatomyositis. HSP. The classic rash is below your waist if you put your elbows like this. So you can sometimes see it from the elbows down, but everything else, and obviously the one that everybody's heard about is the patient comes in with acute abdominal pain. You roll them over and you see a rash on their buttocks, and you think they've got appendicitis, and you go, oops, this is HSP. 10-year-old boy presents with a history of hematuria for the past 8 months. And he has 1+ proteinuria. The hematuria is more pronounced when he has an upper respiratory infection. He will likely show which of the following signs? A low C3, a urinalysis with calcium oxalate crystals, a urinalysis with a specific gravity of 1020, a pH of 5.0, and an RBC cast, or evidence of hemolytic anemia on a smear demonstrating, I can't pronounce these things, angiocytosis or polycytosis, and a very few platelets. Bingo. What does he have? He has IgA nephropathy. IgA nephropathy is a disease where they often have microscopic hematuria, but with any minor infection, it becomes gross. And then as soon as they get better, it disappears, although you can usually see it on your exam if you do an exam in the urine. They have, remember, PMS, post-streptococcal, membranoproliferative systemic lupus. Those are the 3 diseases with a low C3, so he doesn't have one of those. And this is classic IgA. 6-year-old boy with brown urine and healing impetigo include all of the following except hypertension, dyspnea, periorbital edema, hepatomegaly, or polyuria. Actually, they can get all of those things. This is post-strep. Post-strep is characteristically a disease where you get hypertension, you have gross hematuria, and very low urine output. It's a volume overload state. And my favorite story about that is in the old days when we looked at x-rays on viewers. I was looking at x-rays on a viewer one morning and the radiologist walked by, took a look. Oh, I see you got a post-strep in the house, and kept right on walking. And I said, needless to say, I ran after him. I said, wait a minute. You just looked at a chest x-ray and told me he had post-strep. And he said, well, of course. And he said, well, he's about 8 or 9 years old, bones. And he said, he has a normal heart, but he's got curly B lines, volume overload. And he said, what's most likely to cause that in an 8-year-old boy? And at the time we were in strep epidemic. It was strep. So that's something important in terms of they don't make much urine, they are hypertensive, they do have gross hematuria, and they are subject to volume overload. And the only patient I've seen die was a 3-year-old with post-strep who we limit fluid because their volume overloaded, got into the toilet, drank the water, put himself in pulmonary edema and died. So that's important for you to notice. They often have severe oliguria. Okay. I told Camille I'd make up the 5 minutes, but I only made 4 minutes is what I made up. You can rate that talk. Is there a break? And then there's a break, and we'll be back in 15 minutes.